Of Hope. Welcome to the July 2020 West Virginia State Comprehensive Cancer Coalition meeting. I am reading off of notes because there's a lot to go over this morning. So today, cancer experts, educators, clinicians, survivors, and dedicated volunteers from across the state and beyond are logging into this meeting. We do this with the intent to connect with each other so that we can forge lasting partnerships with benefit to ourselves, our programs, and the people of West Virginia. Together, we work to reduce the burden of cancer in West Virginia, and you're an important part of this. Your voice, your knowledge, your skills, and your passion are essential to the success. So thank you all for joining us today. We had talked a little bit about getting updates for the membership from the steering committee. And so I'm going to go over some of those now. The steering committee met yesterday. Mountains of Hope leadership sends out a survey each year to the general membership to learn what the coalition is doing well, how we can improve the coalition, and determine what we need to focus our recruitment efforts on for the next year. If you've not received this survey and completed it yet, wait for the break and you'll have an opportunity to share your feedback at that time. The steering committee and the membership committee takes your feedback from these surveys, meeting evaluations very seriously. Over the past year, we've worked to provide additional leadership support through trainings and steering committee meetings. Currently, the steering committee is learning ways to combat coalition fatigue, create re-engagement, and tips and tricks to increase membership. The executive team is working diligently to make meetings more engaging, more accessible, more inclusive, and of greater value to you. In an effort to increase transparency and communication between coalition leadership and the membership, I'll be sharing highlights from the steering committee meetings. You can always access the minutes of these meetings for more information on the MOH website. And I have to applaud the entire coalition for your continued ability and willingness to adapt to the many changes we face during the COVID pandemic. Your dedication to continue the high quality work of the coalition is appreciated. Yesterday, the steering committee decided that all Mountains of Hope meetings through March of 2021 will be conducted online due to the fluctuating COVID situation. We will revisit the option to possibly meet face-to-face as the situation changes. Your feedback about online meetings has been mostly positive, and many people have reported that they're able to participate online, whereas before, travel and time were barriers to participation. So to accommodate online participation, the steering committee have elected to have 2 online meetings and 2 face-to-face meetings once per year, even after the pandemic eases or new guidance is issued from the CDC. And the only thing that stays constant is change. So it is with a heavy heart that we must bid a fond farewell to Sarah Jane Gaynor, the Coalition Chair Emeritus, who is leaving Mountains of Hope leadership to further pursue the joys of a well-deserved retirement. Sarah Jane, we thank you for the many years of dedicated leadership and wish you joy in your next pursuits. Only those who have served as Coalition Chair may fill the seat of the Chair Emeritus. In yesterday's meeting, it was decided that if no past chair is found to serve out the remainder of Sarah Jane's tenure, then the position of Chair Emeritus will remain vacant until the next election. And likewise, we must also bid a fond farewell to the MOH Vice Chair, Juliana Frederick. Juliana is now Chair of the West Virginia Tobacco Coalition, as well as serving dual roles in the American Cancer Society Cancer Action Network. With her new duties, Juliana has asked to step down from MOH leadership. Juliana, we wish you great success in your new role, and we look forward to working together as much as opportunity allows in your new roles. In accordance with the bylaws, an emergency vote to fill the position of Vice Chair will happen soon. The person elected will be expected to serve out the remainder of Juliana's term as the Vice Chair, becoming Coalition Chair when my term is fulfilled. They'll then serve as Chair Emeritus for 2 years following that. So I ask you all to please consider applying for this position You can email Lauren if you're interested. Our founding members had some exciting news for us yesterday to share. With the West Virginia Breast and Cervical Cancer Screening Program, they are planning their Women's Health Information Program training for BCCSP screening providers. That training is going to happen on Zoom, September 22nd, 2020. They look forward to rolling out the new patient navigation process that's going to allow reimbursement for providers who identify barriers and successfully navigate women to screening, diagnostic testing, or treatment for breast and cervical cancer. The American Cancer Society is supporting vaccinations that prevent cancer for Immunization Awareness Month this August. Materials for HPV vaccination are available on their website, and Michelle had mentioned she had materials that she would be willing to share. The West Virginia University Cancer Institute is reopening clinical trials and moving back to pre-COVID levels of implementation in that area. And the West Virginia Bureau for Public Health Comprehensive Cancer Program has been funded again. That's really good news. This is the grant that supports the work of us here at Mountains of Hope. The Bureau is collaborating with other coalition partners to create an online access point for the Mountains of Hope mini grants. So this is an idea that's still in its infancy, but the project hopes to streamline the grant making and the reporting processes. So this is an exciting tool that we hope will increase engagement with our community members, and we're looking forward to seeing how it progresses. And there are a few special projects people have been working on as well. So the 2021 through 2025 West Virginia Cancer Plan has been approved by consensus of the steering committee after a few minor revisions yesterday. The plan will now go to the Bureau, and once approved, it will be presented to the membership at large for adoption. Many of you are going to be introduced to some of the new aims in the cancer plan today during the subcommittee breakout sessions, as the teams discuss their upcoming projects for the next grant year. As you discuss your work plans for the upcoming year, we ask that the subcommittees to focus efforts on policy, systems, or environmental changes. Think about how you can incorporate health equity and try to identify resources for survivors whenever possible. One of my favorite parts of the steering committee meeting is the notes of hope. That's the phrase that we've coined to talk about the things that we get to celebrate. And we have a little celebration we get to do this time. So a success story about the Mountains of Hope AIM 14 work group was featured in the June 2020 edition of the George Washington Cancer Center Cancer Control Technical Assistance Periodical. These names are why I need notes. This story highlighted how the work group created a multi-component shared vision strategy and used that to complete 11 key activities that increased lung cancer screening in West Virginia. And later on, I'll put a link to that article in the chat box for anyone that would like to see it. So congratulations on a job well done, on a busy schedule, and getting a lot of work accomplished. I can't wait to see what the end of today brings. Lawrence, all you.
Thank you, Shelley. So we're going to start the day off with our first speaker. Kelly Blake is a health scientist, and she's the director with the Health Information National Trends Survey, HINTS, and she is joining us from the NCI. Kelly's going to share her screen with us, and welcome. Thanks for joining us.
Hi, everybody. Thank you so much for having me today. Can you see my screen okay?
Yes.
Okay, great. Well, I'm so happy to be back with West Virginians. I'm from West Virginia and actually live here. My home office is in Bethesda at the National Cancer Institute, and I'm there about 1 week out of every month, but I telework from Summersville. And so I'm always happy to be talking to groups who work in cancer control in West Virginia. And so I was asked to talk about health equity a little bit today. And so I will go over health equity, health disparities, disparities and social determinants of health, some of the challenges of defining rural that we face in some of the rural cancer control research that we do at NCI and that we fund across the country, give a snapshot of county level cancer mortality, as well as U.S. cancer incidence and mortality by rural urban continuum codes, show some examples of rural urban disparities across the cancer control continuum, discuss some scientific challenges and opportunities, as well as NCI's role as a funding agency. So without being sort of overly pedantic with definitions, I will just start with these distinct but interrelated concepts. So social determinants of health, that's a place-based organizing framework reflecting 5 key areas. Some groups have 6, 7, 8, but generally it covers economic stability, education, social and community context, health and healthcare, and neighborhood and the built environment. Whereas health equity deals more with social justice and the fair distribution of health determinants, outcomes, and resources within and between segments of the population, regardless of social standing. And for health disparities, there are about 11 definitions. This one is from colleagues who recently published out of the National Institute on Minority Health and Health Disparities. Just to say a health disparity is a difference that adversely affects a defined disadvantaged population based on one or more health outcomes. And I'll spend the majority of the day today talking, looking at rural cancer disparities. So to stick with social determinants of health for just a moment, this framework is from the Kaiser Family Foundation and actually includes food and hunger and access to healthy food options as a determinant. Typically that's lumped under neighborhood and physical environment. In other frameworks, it doesn't matter. These are just frameworks that are helpful to think about. But I will say, these are not often mutually exclusive. There are many causal interactions between and among them. And so the contribution of the different component factors of disease determinants and cancer determinants don't actually neatly sum to 100%, despite many published attempts over the years. You guys are likely familiar with Dole and Peto back in the 80s, the McGinnis and Vegi models, that try to quantify the independent contributions of like behavior and genetics and environmental factors to cancer incidence. So, you might see some that say cancer is 40% behavior, 30% genetics, that sort of thing. But really, again, these aren't, behavior, genetics, and social determinants aren't mutually exclusive, and so they really do sum to more than 100%. So it is difficult to quantify, and it can actually be really overwhelming for any given investigator or practitioner, as you guys know, to tackle the social and structural determinants of health. And so we try to focus on what is modifiable and which domains are within the scope of our jobs to address, and then we can target appropriate levers for intervention at the individual, community, and policy levels. So first, defining your population, documenting the existing health disparities, and targeting interventions and resources accordingly. We know that upstream approaches and policy approaches actually shift the distribution of disease at the population level, but also can have perceived or little perceived impact at the individual level, whereas downstream interventions at the individual level have less reach, but can significantly improve the health of individuals. So if you guys are Jeffrey Rose disciples like I am, you'll understand that language from the prevention paradox back in 1985. And all that's to say that, multi-level approaches and comprehensive strategies, of course, are preferable to single-level approaches and single-level strategies, especially because, most of these are very interconnected. And so when we're funding research, and especially rural cancer control research, we do put an emphasis on multi-level approaches. So speaking of defining a population and documenting the disparities, NCI 4 or 5 years ago sort of undertook this emphasis on rural cancer control, starting with a meeting around the definitions of rural and rurality. And you guys likely know that there's no single accepted definition of rural. There are 15 federal definitions at least that have been developed and revised over time and are often used by agencies to determine which regions are eligible for certain federal programs. But all of the taxonomies of the federal definitions definitions are place-based. And so they often deal with only geography and like population size and population density, and don't actually discuss the more or include the more important demographic, cultural, and economic differences that make rural areas distinct and heterogeneous. But they are useful nonetheless because we are in the business of sort of quantifying things, and we need some numbers and codes on which to base our research. So the most frequently used we found in public health research are the USDA Economic Research Services Rural Urban Continuum Codes, the RUCCs, and the Rural Urban Commuting Areas, the RUCAs. And those produce around 46 to 59 million people who live in rural counties in the United States. So that's 14 to 19% of the US population. And so this is just a snapshot of rural and urban America. The gray represents non-metro or rural. Those terms are often used interchangeably. And so, you know, there are more rural counties in the US than urban counties, but as we know, more people live in urban areas than in rural areas. And of course, throughout the Appalachian region, there are actually a lot of urban areas in Appalachia, even though we typically focus on the rural areas of Appalachia. And then in terms of county level cancer mortality rates and the rural cancer burden, we know that individuals in rural counties have an 8% higher overall cancer mortality than those in urban areas, and that there's a rural urban disparity in mortality for lung, colorectal, prostate, and cervical cancers, and higher cancer incidence rates in rural areas for many preventable cancers, including lung, cervical, colorectal, oropharyngeal, and melanoma. And you'll note here the high rates in the Appalachian region, and especially in eastern Kentucky, which has the highest cancer rates in the US, as you guys likely know from working with our neighbors. And just to, I'll say, while overall cancer incidence and mortality rates are declining for urban areas across the US, it's actually not the case for rural areas. So for many rural populations, cancer mortality isn't decreasing. It's either steady and in some cases rising. And a lot of that is due to less access to screening and oncology care. So people are diagnosed at more advanced stages, which can affect prognosis and treatment options, but also social and behavioral factors and social determinants certainly contribute to poorer cancer outcomes. So I'm going to quickly go over a study that we did and published in CEBP back in 2017, again, when we were starting our focus on rural cancer control to really make the make the case for investing in this area. And so we used the SEER registries for our cancer incidence data. So you guys likely know that SEER includes 18 registries across the US, each of which captures 100% of the incident cases in their catchment area. And SEER covers about 30% of the US population. We looked at 5-year incidents from 2009 to 2013 and reported cases per 100,000 people per year. And for cancer mortality rates, we use both the SEER and NCHS registries covering the entire US population. Looked at county level rurality by the rural urban continuum codes 4 through 9, which represent rural. And those are calculated based on county's population size, degree of urbanization, and proximity to a metro area. And they draw on the 2010 census. And then this is a really simple descriptive unadjusted analysis using t-tests to statistically compare the rates for metro versus rural areas using SEERStat and SAS. And so in looking at this, again, the rural counties are those in codes 4 through 9. And what we see is that there are about 2,000 rural counties in the US, and that represents about 10% of the population in SEER. And in our study that we found that for all cancers combined, cancer incidence was 2.7% higher in rural than in urban areas, and cancer mortality was almost 10% higher in rural than in urban areas. And then just in terms of a result summary for individual cancer sites, for cancer incidence and mortality for cervical, colorectal, kidney, lung and bronchus, melanoma, and oropharyngeal, the incidence and mortality rates were higher in rural counties in the US than in urban counties. And you'll especially see the lung cancer incidence, being almost 30% higher due to our greater tobacco use in rural areas. But interestingly, for 3 cancer types, the ones in the purple boxes below, breast, liver, and thyroid cancer incidence are lower in rural areas than in urban areas, and liver cancer mortality is significantly lower in rural than in urban areas. And if you guys are interested in sort of parsing the data and sort of keeping track with changes over time, there are some other important studies that examine rural and urban disparities in cancer incidence and mortality. Many of them show the same results as our study, especially for the preventable cancers in terms of incidence and mortality. They use different registries. Some use the NACER public use data set, some use NPCR and CR, and so they're just 2 that are listed here. I will say, CR is more urban than rural, and so in our study, restricting the, CR really gives us those rural areas in Kentucky that drive rates, followed by Iowa and greater Georgia. So the rural areas in Kentucky, the poor Appalachian counties on the eastern side of the state, as I said, have some of the highest cancer rates in the country, while many of the states in the middle of the country that have a lot of rural areas actually have relatively low rates. And so the difference in sort of all cancers combined in our study is really probably related to Kentucky driving the rates in CR, but nonetheless, again, across the board for the preventable cancers, we're seeing higher incidence and mortality in rural than in urban areas. So why? Well, you guys working with the, West Virginia Comprehensive Cancer Coalition and working in rural areas know that across the cancer control continuum, and I'll give examples from each domain of the continuum, we have higher risky behaviors and lower preventive behaviors. And just to go over a few, so you guys well know that, we have higher rates of cigarette smoking and smokeless tobacco use than in urban areas, and that rural youth are more likely to use tobacco products and use them more frequently than their urban peers. In terms of diet, weight, and physical activity, we have higher rates of obesity, lower rates of physical activity, and poorer diets in both rural adults and youth. Alcohol is a little paradoxical in rural compared to urban areas, so we actually have higher rates of alcohol abstinence in rural areas, but those who do drink have a higher prevalence of current alcohol disorder and of individuals exceeding daily alcohol limits. In terms of UV exposure and some protective behavior, rural Americans are less likely to wear sunscreen, and we have higher indoor tanning use among rural teens than urban teens. And with HPV vaccination, rural HPV vaccination rates are 10% lower than in urban areas. Rural populations are less likely to know that HPV causes cervical cancer and other HPV-associated cancers, and strong recommendations from providers for HPV vaccination are less common in rural than in urban areas. And then in terms of the other domains of the cancer control continuum, these are just a few examples. I won't read them all, but rural residents are less likely than people in urban areas to be screened for breast, colorectal, and cervical cancers, and also less likely to receive follow-up after abnormal screening results. More likely in rural areas to be diagnosed with more advanced breast cancers. For women, in terms of treatment, there are several rural-urban differences, including, rural residents being less likely to be enrolled in clinical trials. And with survivorship, most research actually doesn't indicate that that rural residence is independently associated with substantially worse cancer survivorships, but rural cancer survivors do experience worse quality of life and mental health outcomes than survivors from rural areas, and rural cancer survivors are also less likely to use hospice at the end of life. And then in terms of some Appalachia specific disparities in cancer beliefs, I have these tables on obesity related beliefs, on sun safety related beliefs, but I'm just going to show you some here that are kind of about general cancer beliefs. These are from the Health Information National Trends Survey, or HINTS, that I direct for the National Cancer Institute with a great team of other survey methodologists. And these are public use data we field every year. We're going back to biennial, so it'll be every 2 years starting in 2022. But The survey seeks to understand how people seek and use cancer information from the public information environment, different beliefs and behaviors associated with cancer. And so for the 5 cancer beliefs listed here, you'll see that for 4 out of 5, Appalachians were more likely than non-Appalachians to endorse many of these beliefs. The good news here, though, is that Appalachians were not more likely than non-Appalachians to say that there's not much you can do to lower your chances of getting cancer. So that is an intervention opportunity to build on, and the other beliefs are modifiable. Going back to, my previous slide on focusing on what is modifiable, since social determinants often can be so overwhelming, cancer beliefs are certainly part of the trajectory and part of things that we can change. There are some scientific challenges to working, as you guys know, doing research in rural areas, and one is the heterogeneity of rural. So rural Alaska and rural Mississippi are different from the frontier areas versus Appalachia. And also, just in terms of quantifying disparities, the grain size of counties is really problematic for rural cancer control research. So for example, Iowa has 99 counties, Arizona has 15. And so some of these larger and smaller counties have a lot of variability within them and within the rural areas and populations. And so it makes it difficult, but not, it's not an insurmountable challenge to get through. It's just something to consider in doing research in rural areas. And then there are also analytic challenges with small data when the size, dispersion, and accessibility of the population make it difficult to obtain adequate sample sizes to detect power, to have the power to detect differences in any given cancer-related outcome. And then more challenges and strengths of rural, again, just thinking about those social determinants, and you guys well know from working in West Virginia, that rural America has higher poverty rates than urban areas, lower educational attainment, higher proportion of elderly, fewer resources for public health infrastructure, insufficient transportation, and broadband. These aren't anything that you guys don't already know. Mistrust in institutions and government programs, cancer-related fatalism, hospital closures. But there are a lot of strengths in rural areas too that I'm sure you guys are leveraging to inform your intervention development and providing services. And those are sort of the strong social relationships and social networks, social support, resilience, values such as self-sufficiency, independence and autonomy, strong local and community-based organizations, and connectivity across sectors and community cohesion. And then just to draw your attention to the bar chart for a moment, because, at NCI, we don't want anybody to think that focusing on rural populations prioritizes white Americans. So we always make it a point to emphasize that there are large racial and ethnic minority populations in rural areas, especially in the South, where overall cancer incidence rates, not just specific site incidence rates, are higher in rural than in urban areas. And actually, today, 1 in 5 rural residents identifies as a person of color or as Indigenous. And so the dual burden of rurality and poverty disproportionately affects racial and ethnic minorities living in rural zip codes. In fact, as you can see on the bar chart, African Americans living in rural areas had the highest incidence of poverty anywhere in the U.S. in 2017 at 32%, followed by rural American Indians and Alaska Natives at 31% and rural Hispanics at 24.5%. So these are well above the census poverty rates, which were in 2017 around 13% for the United States overall and 16% for non-metro or rural counties overall. So in many cases, the poverty rates for rural, racial, and ethnic minorities were more than triple those of rural areas overall. So just want to make a point to point that out. So in terms of NCI's role as a research agency, having worked in West Virginia and really wanting most of our funding to be going toward direct services and education and public health, it can be sort of hard to think about how much we fund for research, but that is our role at NCI. And so we do our own intramural research as well as funding the extramural community at the WVU Cancer Institute and other cancer centers around the country and universities around the country, and can really leverage that extensive research infrastructure and grant portfolio for rural cancer control, encourage more grant applications focused on rural populations, programs, extend the reach of our clinical trials program, engage our NCI designated cancer centers, of which there are 71. In rural cancer control research, there's a new community outreach and engagement requirement for the cancer center support grants. And a lot of the cancer centers have been focusing on rural cancer control, which we've been really gratified to see, and also support partnership and training of new investigators. And so, as I mentioned, in terms of our leadership in this area, it really started 4 or 5 years ago with an emphasis on rural cancer disparities that Bob Croyle wrote about in some of NCI's Cancer Currents blogs. There have been at least 3 workshops and research meetings dedicated to rural cancer control. We did 2 rounds of administrative supplements to the P30s, to the NCI designated cancer centers for rural cancer prevention research. We've had 2 rounds of an RFA focused on detection or treatment, on improving the reach and quality of cancer care in rural populations. And then for FY22, this is forthcoming, and something I'd really like to see you guys come in for is an RFA that I'm leading focused on social and behavioral intervention research to address the modifiable risk factors for cancer in rural populations. So those 5 that I talked about earlier: tobacco, diet, weight, physical activity, UV exposure, HPV vaccination, and alcohol abuse. And so that RFA will be out this fall, and the first funding will come around December of 2022. And we're going to be funding 2 rounds. The grants are $700K per year for 5 years. So they're large grants with plenty of funding for community partnerships and meaningful contributions from community groups and members. And so we hope that that ends up being a really successful RFA. And then for others, in terms of current and past funding opportunities related to rural cancer control, they're listed here. You'll have my slides, so I won't go through them. But there are also many more, like our parent announcements and omnibus announcements, and also topic-specific announcements could have a rural focus. So you don't have to apply just to these ones or to the one that I mentioned before that's coming out this fall. Really, any of the parent announcements to NIH could have a rural cancer control focus, and we really encourage it and hope to see a lot more research in this area. And so with that, I'd be happy to entertain any questions. And I'm sorry, I wasn't able to see the chat as my screens were up. So if there are any questions that came through the chat, you'll have to ask me now.
Kelly, that was really exciting. I'm very interested in the part about the modifiable factors. One of the things that we look at is the perceived cultural norms around cancer in West Virginia, and how we as a coalition can influence that cancer culture to grow people's ability to say, I can do this action to take action against cancer. Yes. How would you approach that? How do you think is the best way to reach the rural population with those positive messages?
Yeah, it's a great question. And so, as I showed on some of those cancer beliefs slides, that's sort of where our role has been to just sort of, these are things that you guys know intuitively and anecdotally from working in these communities, but to actually document what the beliefs are is the first step. And so we've done a lot of that at the national level. And I will say too, in our Health Information National Trends Survey, we had an oversample of Central Appalachia that was paid for by the University of Kentucky. And so those codes are available. I'd be happy to run any of that data for you to look at Appalachian versus non-Appalachian beliefs. Again, first to document what those sort of beliefs and what myths might be endorsed in rural or Appalachian areas versus the rest of the country. And then we also look at rural identity. So I know you guys have probably worked with Electra Pasquette a lot, Electra Pasquette from Ohio State. And so she actually has a community identity scale and a rural identity scale. Again, this is more research oriented, but it's sort of surveying your populations in the groups that you're working with to see where they are on a continuum of identity and where the opportunities are for intervention if you do see mistrust in government programs and things like that. And so it is just one of the, multiple things to think about when you're designing interventions. And then, of course, there's no substitute for actually asking people. And so starting with the qualitative research and the focus group research to really make sure that your interventions are designed to address the beliefs and concerns and culture of the local communities, I would say.
Thank
Hi.
you. We should stay in touch.
Yeah.
So this is Summer Miller. I'm the coalition facilitator. I am actually monitoring the chat, so I've been trying to keep an eye on what folks are posting. So, you know, a lot of folks said thanks for the presentation. It was really great. I do have a question here from Nicole Stout. She was asking when the new RFA for social behavioral will be out. You mentioned the fall, but she missed the full name of it.
Exactly. So it's, what did I say it was called? Social and Behavioral Intervention Research to Address Modifiable Risk Factors for Cancer in Rural Populations. And that will be out this fall, probably in October. And I believe the first receipt date is going to be in January of 2022. And we'll have another receipt date like around June of 2022. And the first grants will be funded around December of 2022. So there's a lot of time actually before the first receipt date. And we actually asked for 2 receipt dates so that if grants don't do so well and want to revise and resubmit, there's another opportunity for it. So we'll have 2 receipt dates.
She also just wanted to clarify that that's for 2022, not 2021.
Exactly. Sorry. So the PDF that I sent around had 2021. That was a mistake. So the funding is 2022, but the announcement will be out this fall, 2021.
Okay, thank you.
Okay, whatever. I'm confused.
Oh, I'm sorry. Can I help clarify?
No, you did say, you just said the RFA will be out fall of 2021, but this is 2020. So.
Oh my gosh, you're right. I'm so sorry. Yeah.
Okay.
So it'll be out this fall. I'm thinking fiscal year and not calendar years. Sorry. So yeah, it will be out this fall with funding in FY 2022. I'm so sorry. I misspoke. So let me follow up with Lauren and send you guys the exact dates and the months that the receipt dates will be, and I'll send that timeline so you'll have it. Sorry about that.
Oh, that's great. I appreciate the clarification. Thanks. Now I'll be looking for it. Thank you.
Good. Sorry.
Hey, Kelly, this is Stephanie Kennedy Ray. I am very interested in the poverty data that you were discussing. And as a coalition, you know, we're always focused on policy systems and environmental change. And so you have the research side of the house, but then you have this whole PSE intervention side of the house. And I'm wondering if you would have advice for community coalition members around addressing this whole disparity related to poverty in rural areas and cancer mortality rates.
Yeah, it's such a good question, Stephanie. It's good to see you. So it's really hard, right? This is one of the things I was mentioning that's a social determinant that feels really overwhelming and is kind of without of our sort of wheelhouse in cancer control to solve. I mean, many people maybe are in the position to, you know, have the political will and sort of are in a position to help with economic stability in different areas. But it is really difficult. And I would just say in terms of interventions, you know, it's just important to assess it and address it in the interventions and you know, just understand that your participants and the people that you provide services to likely do have many more priorities that aren't cancer prevention and control, right? Like there are many other things that are at the top of their list that they're worried about, and so cancer prevention can fall way down on that list.
It looks like we have another question here from Sarah Barton, and she was asking, how do we get the PDF? Sarah, are you asking about the RFA, or are you asking about something else?
I was asking about the one that she said she had sent out a PDF about the
Yeah, sorry. So I sent Lauren a PDF of my slides, and on those slides, the rural RFA said FY21, and in the ones I showed today, it says FY22. But so Lauren has the PDF of my slides, and then what I'll do is follow up with Lauren or others to just as soon as the RFA hits the NIH guide this fall, I'll be sure that your coalition is made aware of it in case there are opportunities for you guys to apply.
We'll just ask Lauren to send that out on the listserv. Once we see it hit the airwaves, we can forward it through the listserv to anyone on this, on our listserv, which is well beyond the number of people on the call.
Right, great.
Great, Kelly. Thank you so much. And yes, I do have your slides, and I will send them out as well as the next speaker. I'll send them both out after the meeting. I do have a quick poll question as a follow-up to Kelly's presentation. So I'm going to put that up, and I'm going to give you 2 minutes to fill it out, and then we'll get started with our next speaker.
Thanks, Kelly.
Thank you, guys. It was really good to be with you today.
Thank you.
Thanks, Kelly.
Thank you.
%80 of you have voted. That's awesome. Thank you. All right, I'm going to end that. And I'm going to welcome our next guest today. Dr. Scout is the Executive Director of the National LGBTQ Cancer Network and the Principal Investigator of the CDC-funded LGBTQ Tobacco-Related Cancer Disparity Network. And he has joined us today to give us a presentation. Thanks for joining us. Well, he had joined us. He might be muted. Yes, it is. There
Can you hear my audio now? I've got mute on the screen and on my phone as well. I'll try and get all of those off. Hi, everybody. Hi, West Virginia. And I think I can share my screen too, right?
Yes.
Excellent. Let me do that. And then just a second. Let's switch to presentation. Cool. Can everybody see it now? Yes. Thank you for the nods. I appreciate it. And let me actually get the comment thing up too. So, oh, I can't see comments, can I? Okay. Well, then I might be dependent upon you to talk to me about the comments, Lauren. Okay. Thanks, everybody. And I appreciate, no, I don't appreciate not being in West Virginia. I appreciate talking to you virtually, but I actually really enjoyed all my trips to West Virginia. So the idea that we have to do this while I'm in Rhode Island is certainly a letdown to me. But that said, I am very grateful to be here. And I'm also interested because I realize that I don't know how many people might have been here, because I know this is about the 4th or so time I've presented in West Virginia. And that means that unlike some places I present to, there could be more of you who've actually seen one of these before, potentially. So I actually, Lauren, I probably should have asked you to put that on a poll initially, but if you have, please shout out in the comments that you have seen it before, because I appreciate that. And it means, as I was thinking about what to talk about today, I kind of decided to jump past some of the things that I might say to people who had never seen it, because I feel like now I have higher expectations for West Virginia than I do have for lots of other places in the country. So I'm interested
a couple of
to
poll
see
questions that we could start with if you want to go, if you want me to put those
already.
up.
Yeah,
All
sure,
right.
go for it. I wish I could see all those comments. I know they're trying not to interrupt a presenter, but what if I multitask well, for criminy sakes?
I
What do we
could
got, Lauren?
probably, I could make you a co-host and you could see the comments as well.
Okay, that'd be great.
I'm going to launch those poll questions and then I'll see if I can add you here.
Oh, that's right. You've got those. Exactly. Right.
Yes. And I added a couple.
That sounds great. And while you're filling out those, I have another question. This you could just put in the comment section. Does anybody know what mask I'm wearing now? That's my question. Yay, I can see the chat. That's so much better. Exactly. Good job. Good job, Shelly. Good job, Megan. All right. I guess I kind of said it to everybody. Yeah, this is the trans flag. I've also got my, obviously, the rainbow pride flag mask. I have my bi mask, but it's down in my car right now. So I didn't go and get that, which is a pity, because that's probably the one I should show the most, because people may not be as familiar with it. I had to buy the material special, and then I had to sew them myself because I couldn't find a way to find them anywhere. But luckily, my Nana taught me how. All right, are we good? No, not done yet. Okay.
There's still people voting.
All right, fair enough. Let's see, what will I talk about as people continue to vote? Please be honest, because I actually really appreciate the people who have more to soak in. Happy belated non-binary day, that's great, absolutely. I know, one of the first things we're going to talk about actually is how there's so many different and new terms out there. And it is interesting because sometimes as I look back on some of the presentations I gave years ago, I'm like, ooh, that doesn't stand anymore. But that's a good thing, actually. It may be a challenge if you're out in community and trying to keep up, but it really is kind of exciting that people are finding ways that they fit in. I'm happy about that.
Okay, we have 70% voted, so I'm going to go ahead and close that poll. Oh,
thank you very much, everybody.
Yeah, it hopped up to 76, so that's great while I was talking.
Good. Okay, so we've got pretty much lots of people being in the center to the high range. That's really great. And then will that disappear or will that stay on the screen?
Oh, you just have to hit X. I'm sorry, I forgot you were.
Oh, I have to exit out. That's okay. That's okay. Okay, good. All right, so center to the high range, which is what I would expect out of West Virginia, because again, you guys set a standard we're trying to get other people to keep up with. That's what I've always said. So let's dive in, and like I said, there's only a half hour here, so I very much, sorry, I gotta get my timer. I very much was trying to pay attention to what were the really important things to make sure I convey to an audience that probably already knows the basics, okay? So oops, sorry. If people don't know who I am and you haven't seen me before, I run one of the 8 CDC-funded tobacco and cancer disparity networks. So I spend a lot of time helping state cancer and tobacco programs do a better job of engaging our population. We also do a lot of resource building and collecting resources and try to share them so that people don't have to build new wheels. And so one of the things I actually encourage you to do is if you can go to the National LGBT Cancer Network website, you will find that there's a way to sign up for our emails. And you will also find that if your organization is not a member, you can, in that same form, become a member. It's totally free, everything like that. So please join that, because we try and create a lot of resources for people like yourself who are doing this work on a local level. Okay, so like I said, the first thing I want to jump into is, where does the terminology stand today? People are pretty familiar with the concept of LGBT. Now it's kind of evolving to LGBTQ+, but there's also some new words out there people may not be as familiar with. So first of all, let me dive in and give you the takeaways for really what you should kind of think about related to terminology. First thing is, don't memorize everything, really, because all these words are kind of new in the in like lexicon or in the word world. As a result, they kind of breathe a little bit. They change a little bit, since they're basically all baby words. So since that's the case, don't worry about being exactly up to date on what today's words are. What you do need to think about is being comfortable using a word if someone uses it to define themselves with you. And the one thing that's probably the biggest issue on is queer, which is a word that has a very negative, pejorative history, but has become very normalized and mainstreamed. So I wouldn't start by saying that someone's queer, but if they say they're queer, at this point, you should absolutely be willing and ready to just say queer back without stumbling over it, because that'll help you look like you're familiar with the communities and not kind of struggling as an outsider. Just have your own term that you use when you're talking about the communities. I usually say communities because we're not monolithic. There's a whole bunch of sub-communities in there, which is why I usually pluralize it. LGBTQ+ is probably the biggest one being used right now. And so that's a really safe, good one to use. You can do with just a Q without the plus, but have your own word you start with. Be willing to echo back other people's words. And then the last thing is, if you have materials that are going out printed, or, you know, I guess no one really prints anything, but put on the web or something like that these days, then I would really encourage you to have community advisors review those to make sure the nuances of anything in written form are going to be exactly the way you want them to be. And we'll talk a little bit more about the strategies to make sure that that's easy too. So this is your takeaway. Don't worry about the details, because they do change. But that said, now let's jump to what the details are. This is actually an Instagram, for LGBT Wales. And the interesting thing is, these are a bunch of, I presume, youngerish folks. I'm not exactly sure, but look at some of these interesting identity labels that they describe themselves with. J is pansexual, asexual, gender fluid. Ave is male to female. Jax is gay, gender fluid. Sarah is bi and pangender. Dylan is pansexual and asexual. And so you can see as these go on that it's really interesting. We've even got, what is it, Anna and Eliana and Ven are pan and demisexual, as a matter of fact. So, or pansexual and demisexual. So you see lots of new terms here that we haven't, or I mean, I guess some of us have seen before, but are not really part of the LGBT, right? And so we're going into new areas. The important thing to know and remember with this, is that basically people are creating terms that really understand where they identify with in the world. And just to be clear, when I grew up, there wasn't the term transgender. There were transsexuals who had an operation kind of thing, and there were drag queens, but there wasn't the term transgender to talk about people who identified as a different gender than what they were born with. And so when I grew up, I was labeled lesbian, but I didn't ever feel like that fit well. And I didn't understand why for myself, I seemed to identify a lot with drag queens. And, later as the word was developed and I understand that there was actually a different element of this identity that fit much better for me, it really relaxed me because it helped me understand there were other people like me in this world. So whenever you see these new kind of terminologies come out here, it means that people are feeling less isolated because they realize there's other people like them in the world. So in general, we love the idea that it's happening. It is a little hard to keep up with though. But I'll give you a primer, and I know these slides are going to come out. So I'm just going to, again, kind of run through some highlights on this because we have a really short period of time. Bisexual, one thing to remember about that is that bisexual folks are usually more than half of the LGBT population. Yet, we are often ignored because we're kind of not completely welcomed by LG, and we're not completely welcomed by the outside community either. Some people say, oh, you're just in the middle, but it's not the case. There's actually a huge number of people identify as bisexual as a firm identity label. One of the ways to talk about how bisexual has a lot of different ranges of identities in it is to say bi plus. Just remember, as you create materials, try not to leave out bisexual, since again, it's going to be the largest group of people that you're talking to. Pansexual is usually considered to be kind of under the umbrella of bisexual. It means something very similar, because sometimes people presume bisexual means only attracted to males or females. And that's not the way bisexuals interpret it. They're kind of like anything. But pansexual has specifically been brought up to say attracted to someone of whatever gender there is at all. So you can see they're kind of analogous. It doesn't matter what someone's gender is, you're attracted to the person and not necessarily restricted by the gender. And then asexual is also a new phrase that we're seeing a lot these days. It has to do with people, it's called a spectrum. Asexual, ace spectrum. Because there's people who range along that spectrum, and asexual usually means someone who identifies as not being a sexual being. So the opposite of sexual, asexual, right? And that means that there's people who decide that that's not part of their life, that's not part of their world. They can opt out of it because they identify for it as now, or maybe it's be an identity label they will have throughout their whole lifetime, who knows. But you can imagine there might be something possibly kind of relieving about just saying, no, I'm asexual. Boom, that is closed. I'm not going to worry about that messy piece of the world because that's just not part of my reality right now. And the reason why it's called a spectrum is because there's also people who are like, there's ranges within it. There's people who are demisexual, and that means you're kind of only attracted to someone after you get to know them, like quick hookups wouldn't work for you, things like that. But just understand, it's actually one of the fastest growing areas of identity labels is this asexual spectrum. Two-spirit, we understand, oops, sorry. I guess that moves us to the next slide. I didn't realize that's what that did. Two-spirit is usually used with the American Indian, Native American population. It does not just mean trans, so that's just something to remember there. And queer, of course, is one of the biggest areas that's kind of, again, an umbrella term for lots of these different identity labels. Okay, next one. Now the gender identity labels. There's just a couple things here that, again, if you have advisory groups for written materials can really help you. Like, for example, we don't like it when you say trans man without a space between trans and man. Why? Because it makes it sound like we're a different species. And instead, transgender is just an adjective to describe the fact that we're, this type of men. So in that way, keep the space, and that way you claim it's an adjective. In the same way, you wouldn't want to say transgenders, because that makes it sound like a different species again. We're not a different species, we're just a type of human. I think most people kind of know that cis is the opposite of trans these days. So if you're not a trans person, then you're a cis person. And then another big area of growing, as we saw in the comments, is NB and non-binary. They both mean the same thing. NB is just the way to say the two initials. And non-binary is a way to then to publicly say that you don't identify as either just male or female, but somewhere in the mix, either between or on a different spectrum altogether, but not in those two boxes. And then genderqueer is the analogous kind of umbrella thing related to queer, but genderqueer also a little bit in the gender area usually means a little bit more of a non-binary kind of approach with people. And then you see some things here, things not to say over there. Transgendered is one of the ones and transgenders are two of the ones I see most commonly in like public writing or government writing that please avoid. And then of course the word tranny is equivalent roughly to the N-word of the African-American population. It's very inflammatory. And I was actually giving a presentation at a comp cancer thing in New Jersey when the head of it put her head down in her hands. I'm like, what? She goes, I just wish I'd known it a year ago before I got written up for saying that to a friend in the workplace, so heads up, very inflammatory. All right, and then the groupings, any one of these is fine. The I added on usually stands for intersex. SOGI is usually used around surveys because it stands for sexual orientation, gender identity, and it means have you added SOGI questions to surveys. And then SGM means sexual and gender minority, and that's often used in government places as another way to keep the acronym a little bit shorter, but means the same thing as LGBTQ+++++. All right, with that, let me just check back with our comments. Any questions about anything I've said? Because I just went through, that in really fast. Lauren, you have a question.
I do have a question.
Oh, sorry, you just have questions public or just for me? Because it was a
I know, it was a public question. I just didn't want to interrupt you. So
Okay.
I worked in disabilities, and so a big thing with folks with disabilities is that person first language. And so you were just kind of talking about being a person versus, I think you said something about being a transgender man and keeping that space. So is this a different framework of thinking? Should I not say a man who is bisexual? Should I say a bisexual man?
Yeah, usually, I remember that cartoon from long ago when like the older woman's like, a colored person, and the daughter's like, no, a person of color, right? So they can mean very different things contextually, right? And right now, the way that it's being used in common vernacular is you can say a bisexual man. Okay. You wouldn't say a man who is bisexual usually. And there's, there's no kind of rule around that. It's just contextually that's what's happening now. Any other questions? I'll leave that open and keep watching that in case there is. Okay, last thing I want to say about language is that pronouns are incredibly popular. And actually that non-binary thing I think might save the world because so many youth are identifying as non-binary now. It's amazing. There was actually a survey in California that's saying of youth, like 26% of them identified as non-binary. So the next generation coming up, and that's just general population. Like, we think of about, a very small percent, maybe 4% are queer. 26% of those youth were identifying as non-binary. So, or GNC, gender non-conforming, another analogous term. So those youth are going to blow our mind as they kind of take their power and do more to decide where they actually fit in this world and not the box that their parents or other adults might have decided for them. But pronoun use. So you are probably used to people at this point who want to ask for they or the singular they as their pronouns. Remember that that's actually something that has been used for a long time. It's not even a new invention in history. And I just want to say that if that's the case, respecting someone's pronouns can be a really powerful thing for them. It can be a really huge way to make them feel welcome and as if you're on their side and as if you're not part of the people who have been stigmatizing to them for their whole lives. So it's an incredibly powerful thing. One of the things you can do is put an tagline, actually, as a matter of fact, I'll do it on my thing right now, is that you can just do something simple whenever you are in a public forum, like, oops, it's funny. I think what I just did was I was about to change my name to Scout He Jim, but I meant him, of course. So you see on my name now, if you can, that I just put my pronouns after my name. You can put this on your email tagline. You can do it once, and every single person who sees your email who's gender nonconforming or LGB will realize that you're saying that as a way to be welcoming to us. So it's really powerful, small act to do to make a difference. And if it's hard for you to, it's hard for all of us. If you know someone is she and then you're saying he, you're going to stumble. If you mess it up, just say sorry quickly, move back. And a secret on this is if you're really having a hard time, like using singular they or the right pronoun, have imaginary conversations in your head with the person until it feels a little bit more natural. And then it's usually easier for it to come out in person when it comes up. All right? Still asking. Any questions? Nope, I've been so clear. I'm not sure I trust that, but I'll take it for now. Feel free to throw them up there in the chat box. All right, next thing that's just a shifting point with the population is data. Two things I want to convey related to this. One is the number of people who are identifying as queer is really moving on us. Like I said, those youth are feeling more free to identify as queer, but also more adults are feeling more free to do so as it gets a little safer. But just as an example, this is just for LGB, the number of people on recent behavioral risk factor social survey, which is, the big surveillance system that's full population, everything like that, the number of adults who identified as queer. Now look at that same thing for the YRBS, its youth counterpart in the same year. You can see the number of youth that are identifying as queer is almost twice as much. And actually, I figured it out. I think it's like the year 2543 that at this trend, the population will be majority queer. Of course, we don't think it's going to keep going that much, and I probably won't live to 2543, which would be sad because that would be fun. But you still see that we don't know how many people, as they feel safer, might actually identify as queer. The number's going up. So that means you could have more people who are queer in your patient population or the people you reach out to than you're even realizing. So safety equals disclosure for a lot of us. And that as safety is increasing, disclosure is increasing as well. All right. This is making a big difference around the country too. Probably the last time I would have made a presentation in West Virginia, I would have told you that there were 9 million queers in the country, which is about the population of the state of New Jersey. It has so completely shifted. It's now 14.7 million. And that is really equivalent to the population of these 3 states put together, Rhode Island, New Mexico, and Georgia. And remember that despite that, even the Supreme Court ruling did not guarantee us civil rights at a federal level. It was a piece, a small piece of the civil rights pie. And so understand that this population of people in the United States realize we do not have federally designated civil rights. Sometimes we have it in cities we go to because they passed it in the city or in that state. But if I travel around the country, there's no assurance, which means in lots of places I can go and present in a hotel, but if they kick me out for being trans, I have zero legal redress because I have no protections. And remember, we bring that to the table because that's part of our caution and concern when we come and dealing with anybody who represents themselves as being from the government, funded by the government, things like that. So the other aspect of data is what do we know about a lot of our risk factors? So how can I talk to you about LGBTQ lung cancer rates as compared to others? Understand our smoking rates, our tobacco use rates are 50% higher. Our cigarette use rates are 40% higher than the general population. That persists into the youth, that persists in the e-cigarettes, that persists into a menthol disparity as well. So we know cancer, at least a third of cancers are caused by smoking alone. If I've got that level of tobacco use and smoking disparity in my population, of course I have higher cancer rates, right? Yes, right, that's absolutely true, but I can't prove it to you because the data aren't collected. Now, we get these data usually from electronic medical records. And unfortunately, electronic medical records are one of the last areas where we're not collecting are you LGBTQ, which is sad because we really need these cancer outcome data. So if you're working with an organization that does any intake at all, the question is, are you asking if you're queer on the intake? There's a recent study showing even in a place as vulnerable as an emergency room, 90% of us are willing to disclose, but 67% of doctors think that it's inappropriate to ask. So obviously, that's an educational misinformation point that we need to close the gap on. So lots of us are willing to disclose, but usually we're being forced in the closet because people aren't asking. So we do have a full webinar archived, and I can give you a link on it for anybody who contacts me, things like that afterwards. This is just an example of what an intake form might look like. This is from a really welcoming FQHC, and they've got this stuff on their intake form. They also have signs that have LGBTQ stuff and an LGBTQ non-discrimination statement in their waiting room. I'll talk a little bit more about them as we go to the strategies to make sure that you're welcoming. And so now, how am I doing on my time here? Okay, I'm going to make this. I got, what, 8 minutes? Is that what I got, Lauren? Okay, if anybody has questions, please ask them very fast. Okay, so what are the strategies? This comes from our top 8 things or 7 strategies that we have as best practices for cancer engagement with the queer populations. You probably have seen some of these before. So I guess really my question for you is how many of you have taken steps to actually implement any of these in your organization, okay? They're not rocket science, but trust me, they make a huge difference when we're looking at your organization, how welcome we feel coming to the door, walking through that door and getting services from you. So the first one is your organization welcoming to the LGBTQ employees? Because trust me, the best thing you can do is be welcoming to those employees. Oh, this is actually interesting. So This is all the places around the country where we're not protected from discrimination. And again, that Supreme Court ruling only put a patchwork of a piece of these protections into place, not all of them. So unfortunately, this map is actually still stands. One of the ways you can welcome your employees, and do we know if West Virginia has non-discrimination for, oh, I have wiggle room. Excellent, I have a couple more seconds. Excellent, thank you, Lauren. So do we know if West Virginia has non-discrimination for LGBTQ in employment? Oh, actually, what am I saying? Now they do because of the Supreme Court. Okay, so, but did you have it before that? Can I ask that?
Only on a local level. Some municipalities had it, but it wasn't statewide.
Okay, thanks a lot, Shelley. I appreciate that. Okay, so one of the first things you want to do is you want to make sure that, and again, to be in compliance with the Supreme Court, you should already do this, that you've got non-discrimination included in your employment, but also in all your non-discrimination language. So, and understand the interesting thing about this is people who are used to being covered in it don't usually read the paragraph of non-discrimination. But trust me, being from a population that's only occasionally covered, I read that paragraph every single time looking for sexual orientation and gender identity in the middle of it. So it's kind of a great thing to make sure if you have that up in your waiting room, the people it doesn't refer to won't even notice it's there, but I will be like, look at that and reading it. So it's one great way to also show the client population that you're welcoming. But importantly, for your employees as well and your contractors, they've got to know that they're welcoming. And by employees, I don't just mean non-discrimination statements. I actually mean valuing your employees because they are the best resource you have, your queer employees, to figure out how you can do better queer services. I can give you some big general guidelines from, the federal perspective, but they know what you're doing, where it's good, where it's not necessarily good. They just know that the operations of your agency. So I really encourage you to do what the federal government has done here, actually is still done, even though this is an older picture, that they have a strategic advisory group of the LGBTQ leadership and LGBTQ allies on this topic that is a formal functioning body of HHS, and then they have those same bodies in lots of the different, like CDC, NIH, places like that. So get those queers to actually have time where they're paid at work to kind of think to themselves, how can we do a better job to serve queers? Is one of the most powerful strategies you can have as an organization. You say, but Scout, we're an organization of 8 people. We don't have a lot of queers yet. Well, I hope you do sometime soon. But in case you don't, the next strategy is for you. This is just another organization that shows all the ways that they actually have a lot of different affinity groups for the different kinds of disparity population leaders. Oh, sorry, I jumped too fast to the next topic. Remember, employment discrimination is a really huge issue, so that's another reason why you need to make sure that you're not just complying with the law, but really putting, your money where your mouth is on that. And then another great thing around your employees for this is, of course, just to make sure that you have all gender bathrooms as well. Okay, so yes, Abby says to everybody, does inclusive marketing promotion help the LGBTQ community to feel more welcomed, or is it seen as performative? Well, no one likes to have the token queer, like as the best friend in all the wedding movies, right? But we do see that there's like more now. We're beyond tokenism in a lot of these places, and that does make a huge difference. So I'll say this, truth be told, when we were the token queers in the wedding movies, that was something, and that was better than nothing, and it was great. It wasn't as much as we wanted. And now that we see more of it in more places, that's absolutely better. So if you're like that 8-person organization, you don't have a lot of queers on board yet, you're hoping to hire a whole bunch of queers soon, but until you do, get queers on your advisory group, because most everybody has an advisory group if you're a nonprofit. So if you don't have them in your staff, or even if you do, make sure you also have them in your advisory committee. I'm right now working with the Comp Cancer Center in North Carolina, and they're like, we don't know the queers. And I'm like, you silly fools, I'll try and get you some. So just like reach out to whoever you know to make sure you can get that in-house expertise. Because what I'm saying with these first 2 strategies is you want long-term thinking in your organization or on behalf of your organization how to do it better. A half-hour webinar is not going to actually get huge change. That long-term thinking is going to be the follow-through to make some of these things actually happen. Good question. I'm going to ask that actually a little bit later. So just as an example, the American Society of Clinical Oncologists tried to change what they're doing related to queers. The first thing they did was they convened a queer task force and got like 6 volunteers for it. And next thing you know, that now they're doing all sorts of stuff related to queer changes at ASCO. Okay, third strategy is, as I said, if you're not collecting our data, you're forcing us to stay in the closet. When you force us to stay in the closet, you're not only cutting off our own ability to like write proposals and things like that because there are data that are out there, but you're also missing an opportunity to show that you're welcoming to the population. When we see questions on intake that are worded well and are appropriate, it's one sign of welcoming. And when you put questions on intake, also just a note, they can be susceptible to people complaining, which is why you should educate up your stream to say this is why it's important, and or have your front line receptionist, things like that, have a line to say if someone says, why are these on here? All you have to say is, this is one of the disparity populations. We want to make sure that we're serving them adequately. And that usually if someone has a concern, they're like, oh, okay, they can't really argue with that, right? So put the questions on your intake, on your evaluation, on your complaints. So whenever you're asking demographics, just get used to the idea that we want to have SGM as part of those demographics too. That was, this was actually a picture of the measure as it used to be on the North American Quit Line Consortium, Quit Lines. And then this is an example of how a large hospital system started the process of adding sexual and gender minority data collection to their intake. But they also did it as part of a larger process where they got all sorts of information around where they needed to be welcoming as a hospital, what kind of steps needed to happen. And they did all this with community advisors and staff advisors. That's how they figured out how to like crack all these nuts. Okay, fourth strategy is establish cultural competency standards for your program. And this is just, there's an example here of like, I didn't know why I was being asked to go to North Dakota at one point to do a training of mental health providers. But before I went, there were, what was the number here? Because there were only 6 providers in the whole state, mental health providers in the whole state who said that they're LGBT welcoming in any kind of a public forum. So if you were queer and you were searching the internet head to toe, trying to find some therapist who's welcoming to you, you could only at your best find 6 people. And then were you close to them in North Dakota? Because it's not a tiny state. Chances were not very likely. So after one single training, 70 more providers decided to add themselves to that list. And so you can see that basically it really shows so many of us have the desire and the willingness, we just don't necessarily have the tools yet. So when you set the standards in your organization that here, let us help provide you with the tools so that we can show that we really are welcoming, it moves lots of us from being like quiet allies to demonstrable, visible allies. And so in that way, I'm going to introduce you to the rainbow ripple effect. So your organization has some kind of a core service, but you have a bunch of ways that you then have staff that take that service out to the field, have media that takes that service out to the field, have some kind of a visible public presence. And so in that same way, as Lauren asked, the real question is, how do we see you? Do we see you as being welcoming when we start to interact with you? Because if you have like the dots at the center of the lake being maybe like your doctors, maybe they're trained and they're very queer welcoming or something like that, but you affect people in so many other ways and interact with them. We're not going to get all the way to the doctors if we've experienced problems in the other areas. So just think to yourself, just do a little bit of, as Lauren said, how does the coalition or whatever your organization is show that you're queer welcoming? Do you value your membership? Do you have non-discrimination statements posted up on your website? Do you have specific queer content if you have a website? Like, it doesn't take that much to copy some of the stuff that like we have around LGBTQ cancer stuff. Do you have, if you have bricks and mortar, do you have promotional materials in the office? I actually used to go into Planned Parenthood as a test patient to, first of all, I'd go in and I'd ask for pregnancy tests, which was always kind of an interesting concept. But in addition, I would go in and see what it looked like on the walls, whether they had any indication that they were queer welcoming many years ago. And the sad truth was most of them had no clue. So when I went in, I didn't know if the people I was dealing with were the bigots, were the old school thinkers, or were the people who were, you know, who had a queer son and were trying hard to do anything they could to be a champion for our community. I couldn't tell it apart from my perspective. So if there's one thing that I really encourage you to do, is help us figure it out, because that will help us feel safe. And there's so many easy ways to do it. Again, post that non-discrimination statement. People it doesn't affect, I mean, the people who aren't worried by it won't look at it, but the people who do always look at it or wonder if we're in, we'll be looking at that closely. I was at one training in Maine when literally a bunch of school nurses had competitions to see who could buy the most rainbow flag stickers off of Amazon to put on their school nurse offices all over high schools throughout Maine. It was a delightful moment. Literally something as small as a rainbow flag. And again, you don't have to be perfect, but if you're not showing us that you're welcoming, then unfortunately you're part of that silent majority that is making us nervous and cautious. Another great thing to do is partnerships with queer organizations as well. So what do we think, Lauren? I'm going to actually ask that question out, and let's see what do people have as far as answers. What does, oh, sorry, no, that was a private question. Sorry, I'm going to put Lauren's question publicly and say, you're just stuck on private mode with me, Lauren. That's your problem.
Oh.
So what she asked is, how does the coalition show that we are LGBTQ welcoming? And I'd like to ask people to think about that. And maybe if you can't think of a way, then the next question is, how could you show that you're LGBTQ welcoming? All right, and the fifth strategy is, as I talked about, routinely integrate queer tailored materials into existing health campaigns of any type. So these are just some examples of the types of things that we provide. I don't know if you know, but since we're federally funded, we create a lot of these things. You can take our logo off, and as long as you sign up for our free membership, you can put your logo on. And that means you can distribute this as your own stuff, and it's totally free for you to use. As a matter of fact, if you catch us on a good day, we might even put your logo on for you. So there's there's the cancer infographic we had. Here's some cancer screening outreach things we have. Again, you can put your logo on it. It can be, Mountains of Hope Cancer Coalition can go on it tomorrow, as long as you just say you're a member, and then, we go from there. We give you the art, or you do it yourself, have it in Spanish too. And these aren't the only things we have. So it's not that hard to make sure you've got something that's queer specific. And our information is housed, Sarah's got a private question. Information is housed in the National LGBT Cancer Network website. So it's cancer-network.org. And at the bottom of that, again, is where you can sign up for our listserv, where we send out a bunch of newsletters with resources, or you can also send up as an organizational member, and then you officially get to brand things. You can use these things even if you're not a member, if you don't like the free membership. But in order to put your logo on it, we ask that you just become a member, because that's how we kind of prove to CDC we're working with real humans and not just, playing in a room by ourselves. Okay, so I am almost done, and so now it's down to the time when you've got to start asking these questions in the chat box of me, because I have a couple more minutes. The action steps here: foster your leadership, get your advisors, because that's what's going to give you the pull to keep going with your change steps. And then look from the outside, pretend you're me. Don't worry, it's pretty easy. Pretend you're me, and then think to yourself, what do I see if I was approaching any one of your services? Do I see anything that helps me relax and think that I might be welcome? Obviously I run a cancer network, and yet it was so hard for me to go to a dermatologist to get a cancer screening. I had to have, my partner basically dragged me by the scruff of my neck in, because even though I'm so educated about this, understand the risks, everything like that, that I want to go to a new provider, disclose that I was trans, see how they were going to react. No, so you just really can't underestimate, and yes, it was skin cancer. So you really can't underestimate how hard it is for us to get through some of those barriers. All right, with that, there is our website, and I think our email, and let's see what we got going on for the questions. Is we've got, oh no, well, you see the website at the end there, cancernetwork.org is it? And I got 3 minutes for the questions. Okay, so let's see. You do have an STM advisory committee. That's great. Is that for the Cancer Coalition or for your organization? Intentional recruiting and partnerships, absolutely great point. Yes, bring in speakers like me. Yeah, actually, you know something? We have a series of 7, I'm talking to Megan Ross's comment, if we were able to help the network identify these providers, we could then have a page or infographic on friendly providers and some data encouraging screening. We actually have a series of like, I think 7 or 8 postcards that are like, get screened. They're all cancer risk factor postcards. We developed them originally for Rhode Island, and what Rhode Island did was they put their logo on linking to a page with Rhode Island specific welcoming partners. So if you wanted to do something like that, you could actually even have a series of all these risk postcards for, you know, tailored for queers. I'm sorry I didn't put an example up here, but they look pretty sharp. And then actually have specific West Virginia providers. We also have welcoming screening list and welcoming cancer care provider list on our website. And we would love to get more West Virginia-based providers on it because I don't think we have many right now, unfortunately. The longest acronym ever, West Virginia BSAP, makes LGBTQ cancer screening small media resources. That's great. Excellent. We'd love to see if you have any, please give them to us because we'd love to share them with other people. And Dr. Rainbow Project, I don't think I know what that is. But that sounds great too. That sounds like it. Go ahead.
So the Dr. Rainbow Project is a project in West Virginia that helps providers and offices just identify as LGBTQ friendly. They have a little bit of like flyers, stickers, things like that. If you're part of the Dr. Rainbow Project, you're on their website. They'll send you things to put in your office, that sort of thing.
Looks like
so
you
I
got a
do
couple
have a
provider
big
guides.
question for you.
Virginia too. Yeah, go ahead.
One of the things that we're missing, and specifically I'm thinking about the cancer registry data right now because this came up in a conversation between Steve Blankenship and I yesterday, is we do not collect LGBTQ information. And there's been a lot of kind of question in West Virginia because there's no guarantee of services, and outing yourself can put you at risk for certain things versus the need to start collecting that information so that we can really have the data we need to show those disparities. Where do you fall on that?
Pretty easy answer. I fall on, let's not have the policymakers make the decision for us. Let us make the decision ourselves. Again, you're going to have some of us who will be perfectly fine disclosing. That number will change over time as there's more safety. You will also have a small number of us or our outsiders complain, so make sure you educate to make sure that everybody understands the reason why. But you will also have a large number of us willing to disclose. Like that 90% of people who are willing to disclose in an ER was in 3 different states, and they didn't always have protections in those states. So there are more and more of us willing to disclose on a routine basis. So just please try to let us make the decision instead of you making the decision, because as you know, we can't get any of those registry data until they're actually in the electronic health records to start with. I'm sorry, I'm reading Susan's thing. Yeah, there's a lot of issue around stigma. I think it was recently 81% of medical students reported LGB bias, not even counting T, and that's a large percentage of them. So those people are going to be in the workforce for 40 years. So yeah, we got a lot dealing with that. And with that, I know you are on break. I can't keep you from break. So you have our information here on the screen. You will get these resources, and please feel free to contact us, and please feel free to sign up, become members, or reach out to us for technical assistance, or at least see our newsletters, any one of those things.
I'm going to launch the poll so people can answer that real
That's
quick.
right. Excellent.
And then
answer the poll, and then you'll be able to go.
Yes. Thank you so much. There's several people in the chat, I don't know if you've seen them, that are thankful for your presentation.
Sorry, I'm skipping the chat for a second. Thank you. Excellent. Excellent. And one of you had a private thing to me too, so I know I've got to, yes, we do other trainings. So if you're interested in contacting us, we do other trainings. 2022. Oh, that's way back for the chat. That's another presentation. I think I was confused by that.
I would like you to send me a suggestion of what we could put on our website, if there's something that you know
why don't you first send me your website? Because I don't think I've looked at it. So just send me the link to what the website is.
Yeah, absolutely.
Okay, that sounds great.
We're working
Oh, there
on
we go. Sarah, yes, you can contact us. Yeah, go ahead.
We're working on an overhaul at the moment. I think that'd be great to go ahead and add something. I'm just not sure what we want to add.
Excellent. We'd be happy to make
information
advisement until you get your own advisory people on.
Yeah, that'd be great.
Those Rainbow Caduceus pins that we gave out at the health fairs last year, the year before at conferences, were really popular.
You know, I was down in Atlanta, and Atlanta Police Department, like 5 years ago, had rainbow wristbands. And it was just so impressive because I don't usually think of the police as a safe space. Obviously, that's become quite an issue around the country. And to think that a police department was like specifically trying to do outreach to our communities, like when you're not expecting it particularly, it really is lovely when you see that it's there. And I mean, those pens didn't cost much. The wristbands are like, what, 1/4 cent each kind of thing. So yeah, when we're not expecting it, a little effort can go such a long way.
Okay, I have 77 people or percent that have voted, so I'm going to go ahead and close that. Thank you all for sending in votes. Thank you.
Excellent.
Sarah.
And this is recorded, right? So you will send me the recording so I can get the notes, right?
Yeah.
Okay. Thank you all. I think I'm out of here then. Have it, right? We're on break?
Yes, no, thank you so much. We're going to head to break.
Okay. All right. Take care, West Virginia. Next time, let's have it be in person. Poo on the pandemic stuff. This is annoying. All right. Bye.
Bye.
We're going to go on break, and I'm going to put up a slide that has a link to the membership survey. So if you want to do that while you're on break, or you can do it afterwards, we just wanted to give you an opportunity to fill that out. As we did last time, for those of you that weren't here, turn your video off, turn your sound off, go for a walk, have lunch, whatever you want to do, and we will see you at 12 o'clock.